those big ambitions. And Sarah J. Marsh, who heads the testing programme, put out a tweet this morning apologising to people who can't get a COVID test. And she says that it's not the testing sites that's the pinch point, it's the laboratory processing. How soon do you think it will be before those issues can be resolved?
In the coming weeks, we're working on it incredibly hard. Sarah J. Marsh is leading that. She's an absolutely exemplary leader and we're doing everything that we can. We have had these operational issues that I've talked about. We've had a problem with a couple of contracts, and we discussed some of that in the House of Commons. But it's a matter of a couple of weeks until we can get all of that sorted. In the short term, in the immediate term, we've already put in certain solutions to ensure people don't have to travel more than 75 miles. I appreciate 75 miles is far longer than you'd want to go, and indeed the vast majority of tests are much closer than that. We've also successfully continued the rollout of asymptomatic testing to care homes, even despite these pressures, because of the importance of that.
Thank you. James Davis.
Thank you, Secretary of State. I was pleased to hear you refer earlier to long COVID syndrome and what you're doing to tackle that. There was a paper in the BMJ recently suggesting that up to 10% of those infected, possibly 60,000 in this country, have the condition. And you referred to the long COVID clinics that are being set up. Could you give some idea of the number of those across the country, the level of access to them, and how we're going to make sure that professionals, particularly in primary care, are aware of their existence?
Well, this is a project in England, and I've had discussions with my colleagues in devolved nations about it, but this is an area of responsibility that's devolved. The short answer is they're rolling out, and we need to get them rolled out as fast as possible. At the same time, as I said to Dr. Evans, we've been communicating with GPs, other primary care professionals, to be able to, with the latest insight into how to support people. But unfortunately, there isn't a treatment.
No. It's a good opportunity to highlight the fact that many in the ME, chronic fatigue syndrome community, feel that access to services isn't always what it should be, and I wonder whether this might form a template for improved facilities for them too.
Well, I'll take that point away. It seems very sensible.
Okay, thank you. The Chair was discussing with you provision of urgent care cancer services in particular. I have a question about routine and elective provision, because clearly the longer that is delayed, the more people suffer, but also the system begins to break down in terms of attendances at A&E unnecessarily and so forth. So what is your assessment as to the provision of those services currently, outpatient appointments and elective surgery?
So if we take the two in turn, in terms of elective surgery, in England, the standard of treatment for elective surgery is the goal is to reach 95% of normal over the autumn. And in many areas we've basically nearly got back to normal, but of course that's really hard because of the need for infection control. And in those areas where there's aerosol generating procedures, obviously it's yet harder. And using testing to give people confidence that they are safe. And the recent updates to infection control advice that went out at the start of this month will help to get those elective rates back. And then when it comes to outpatients, there's a good side and a bad side. The good side is there's been a radical switch of outpatient appointments to telemedicine, which has been a very good thing, and actually increased access in many ways. But there's also, obviously, it's been harder to deliver face-to-face appointments, but that is coming back now as well. So on outpatients, because you can use telemedicine which is much better for the patient and much better for the clinician where it's clinically appropriate, actually that's been able to take a lot of the strain. The surgery is much more challenging because obviously you can't replace surgery with telemedicine.
Yeah, indeed. And final question from me relates to the uptick in infections more recently. Many people concerned, are we heading towards a full lockdown again? What does it mean for Christmas? What would you say to people who are worried about the direction of travel?
Well, I'd say that it is for all of us to take this very seriously indeed. And we've seen in other countries that if you don't take a second spike seriously, then it can lead to very serious problems down the track. Now, I want us, if at all possible, to get to a position where we can all have the sort of Christmas that people yearn for. But that will require everybody to play their part, to follow the social distancing, to follow basic hygiene. The hands, face, space concept has been developed as an easy way to remember the 3 single most important things that individual people can do.
Thank you.
Thank you very much. Now we've got Sarah Owen, who wants to ask about some women's health issues.
Yes.
Thank you, Chair. I've got a question about women's health, a very specific one, and then moving on to the predominantly women health workforce. 1 in 4 pregnancies end in miscarriage. I know this from personal experience, having had 2 miscarriages before my rainbow baby. Women have shared their added stress and anxiety of going into hospital for scans and routine appointments during the pandemic without any personal support whatsoever. I genuinely can't imagine what it would have been like without my partner beside me. So could you please explain to these women why it's safe for women to go to pubs with their partners but not have their partners by their side at what is one of the most anxious times for parents?
Well, I absolutely agree with you, Sarah. We've made we've removed national restrictions on people having birth partners with them whilst they're giving birth, and the advice from the Royal College of Obs and Gynae supports birth partners being there, and this is down to the decision in individual circumstances is down to
Secretary
individual.
of State, sorry, that's fine for those that get to the stage of actually being able to give birth, but it's during all of the maternity services running up to that point that I think is in question.
Yeah, okay.
And if it's a question of whether PPE is in still such short supply that this vital support can't be offered, when do you think that will be rectified?
No, there's no problem of a supply of PPE, and we're now, in fact, on PPE, we're now rebuilding the stockpile, so that is a problem that has been fixed. The advice on the ability of people to go with their partners or with their partners to a maternity visit is an incredibly important point. As I say, the questions have been devolved to individual institutions, taking into account the local Director of Public Health's advice on the risk in that area. But I've heard loud and clear the call for better access to maternity services, both during pregnancy and at a birth. And I've also had discussions with the all-party group for maternity and maternal health, and this is something that I've taken up with the NHS, and I hope we'll be able to make further progress on soon.
Thank you. You talked a little earlier about the British sense of soldiering on if you have a runny nose, putting possibly colleagues at risk. Do you accept that by paying just statutory sick pay levels to care workers, that you're forcing them to do just that, even if they're sick or have symptoms, putting themselves, colleagues and patients at risk? I mean, if you couldn't live on £94 a week, why are you expecting care workers to do so, particularly during the pandemic?
Well, we're not expecting anybody to live on that level of income alone, and when it is and for long periods of time, there is the important support that most employers give And we've made changes to do that in the health and care system, not least with the Infection Control Fund in social care, £600 million of taxpayers' money. So this is a really important area. It's a really important area of culture change.
Okay, so you've said that it's a very important area. You gave exactly the same answer to kind of miscarriage support and maternal support. Is there going to be any action on these important areas?
Well, yes.
Okay. I'm going to move on to another question. And it's around bereavement. Too many people have lost their lives prematurely during this pandemic, and too many loved ones have had to grieve alone. This is having a huge impact on people's mental health. Are there plans for the government to look into the options of bereavement bubbles?
I'm so sorry, I missed the end of the question.
Are there plans for the government to look into the options of bereavement bubbles?
The answer is that the rules around social contact for people who are bereaved need to take into account individual circumstance. And I've been clear about how we, for instance, changed the rules around funerals to allow a more liberal approach to people going to funerals because it's such a critical moment. The rules are clear that where there are exceptional circumstances, then people may be able to act differently. This is true, for instance, around childcare as well. Having a set of having people behave in a reasonable and sensible manner around being able to support each other through bereavement, for instance, is incredibly important. Now, none of these things are really straightforward because the nature of social distancing rules are that there are an awful lot of exceptional circumstances that you have to take into account. What really matters when it comes to social distancing is that people follow social distancing where that is necessary, especially around social events, in order for us to be able to act as a society with compassion when people need that extra support in exactly the sort of way you described.
Secretary of State, thank you for that answer. We've heard consistently evidence to this committee that during the pandemic, countries that have perhaps fared better than us have had very consistent, very clear communication, and that communication has been an issue throughout this crisis. And I think it's very difficult to communicate why it is that somebody might be able to go to the pub with a group of people but not be able to be there with a loved one when they are grieving or perhaps going through a very stressful period of their life, such as going to routine maternity services. I really, really must stress that there's the ambiguity that you've just given in your answer, I think, demonstrates the problem. And I've got my last question because I know there are others due to come in. Over 900 healthcare workers have died during this pandemic. Do you plan to meet with the families of NHS and social care workers who have lost their lives during this pandemic?
Yes, of course. I'm very happy to meet with and have done, and have written to some of the families as well.
Thank you. Next we have Taiwo.
Thank you, Chair. Secretary of State, you mentioned earlier that test sites shouldn't be more than 75 miles, but a constituent of mine and his children were directed to a site which was 215 miles away in Moffat only just yesterday, nowhere near Coventry. No parent should have to be put in that position. And this clearly shows a lack of regard and poor handling of coronavirus in towns and cities outside of London. Is this truly acceptable?
Well, it is a challenge. It's an operational challenge. I'd love to have the details of that example because we've put in place a policy of people getting tests within 75 miles. So that's the first I've heard of that happening since we put that policy in place. But clearly, we have this enormous testing capability, and the vast majority of people get their tests locally and get the results back quickly. But as I say, and as we discussed earlier, there have been these challenges, not least with an increase in demand for testing.
It's fine. I wrote to you yesterday, and I hope to get a swift reply from you.
Great. I'll look straight into it and get back as soon as I can.
Thank you. My next question is about social care in England. Over the past 10 years, we can say that social care has been nothing short of woeful. Whether it's been the botched reforms or the lack of funding with local authorities like mine in Coventry, we've had to bear the brunt of the government's failures. This has meant that older people and those with underlying health conditions are at an even greater risk from the coronavirus than the rest of the population. So, Secretary of State, my question is, after such a lengthy delay in bringing forward plans to address the level of care for vulnerable elderly people in England, what is the government doing to address the long-term deficiencies?
Well, firstly, I don't characterise your. I don't agree with your characterisation of social care, where millions of people work incredibly hard to deliver the very, very best of care to people who are often vulnerable and including towards the end of their life, but actually of working age as well. And I think we should support our social care workers and describe the amazing system of love and compassion that they deliver. Over the last 5 years, national funding for social care has increased by 2.4 billion. That was before the pandemic. We then put in the last year, an extra 1.5 billion of funding uplift. And then during the pandemic, we brought in the infection control fund that we discussed earlier, and also gave extra funding to local authorities, in part to support social care. In fact, one of the changes that we brought in that has been very successful has been the discharge fund, £588 million, that runs until the end of this financial year, which allows the NHS to pay the first 6 weeks of social care funding. And I don't think anybody should underestimate the importance of this particular change. It means that when people are leaving hospital, the funding is sorted for 6 weeks, which means that a clinical decision on the appropriate care can be put into place, so whether they should go into a care home, nursing home, or into the community. And then once they're in the right place, the long-term funding package is put in place. It helps hospitals because it means that people can get out of hospital when it is clinically right, rather than waiting for a package to be put together. But it crucially also means that people can go into the right type of social care, whereas previously there was strong evidence that more people were going into into care homes than was clinically advised, and this change of policy that we put in place in the peak of the pandemic has had a very positive impact both on hospitals and people going into the right sort of care. So, I mean, that's a long answer to the question, but we've put in extra money. We've made changes that have improved where people end up in social care that we shouldn't underestimate. And I think it's incumbent on all of us to support the staff who live in, the staff who work in social care, who've done such an incredible job.
Thank you, Taiwo. Have you got any more, or are you done?
Yeah, I just wanted to follow up on that. I do agree that the social care workers are very hardworking and very passionate. But what I was referring to was the past decade of cuts to local government, which has been about 7.7 billion. Now, my question is, how can we expect long-term funding settlements for social care to be announced together with the government's plan for reform? And is your department estimate the level of additional funding that social care needs? And how does the department aim to reach this estimate?
Yeah. So, well, it's absolutely fair to ask that last point in the question. However, it's really important to do so on the basis of the increase that we've seen over the last 5 years, especially in the last year, the 1.5 billion extra spending power, 1 billion from central taxpayers' money and 0.5 billion from an uplift in the social care precept, and then there are these demographic pressures which are going to increase the costs, and as I discussed with the chair at the start, I'm not able yet to give you a figure for those, and that's part of the spending review discussions.
Right. Well, we would be helpful for any guidance you can give us, because we're going to be finalising our report in the next couple of weeks.
Okay.
So obviously, if we don't get any information from you, we'll have to use the external numbers.
Of course. Well, and a lot of the analysis is in the public domain about the various different cost pressures.
Thank you. Now, Barbara had a quick follow-up question, I think, on the pandemic, and then we're just going to finish with 2 brief non-pandemic areas.
Okay.
Yes, I should say I'm in the local lockdown area of Greater Manchester this morning. Like people across other areas of local lockdown, I'm sure my constituents are growing weary of not seeing their loved ones at home, or not seeing friends and family members. To be able to safely lift local lockdown restrictions while we have the higher case numbers that we're seeing now, our local leaders in Greater Manchester have asked for 2 things: extra resources for testing and contact tracing. Most importantly, with teams being led by local directors of public health who are doing a much better job at getting through to the contacts, and proper financial support for people asked to self-isolate. Will the Health Secretary agree to that? And if he does agree to it, how soon will it happen?
Yes. Well, I'm very glad to say that all of that is already happening, and we've put in place support for people to self-isolate in parts of Greater Manchester and East Lancs, and we're watching very closely how effective that is on increasing the numbers of people in the contact tracing system. And we work very closely with one seamless contact tracing system across national and local areas. And the way it works is that the national system essentially goes first and contacts people and manages to get hold of a large proportion of those contacts, and then the contacts where we haven't been able to get there through the mass national system, those contacts are passed to the local authority, who then obviously, exactly as you say, with the Director of Public Health, have got boots on the ground, will have that local knowledge and local intelligence. And it's the...
I understand how that works, today. I've talked about it endlessly with our Director of Public Health, but it's not happening in the way you describe. What our Greater Manchester local leaders are asking for, and they're asking for it in other parts of the country, is for the Directors of Public Health to lead the effort, not for them to wait to be past contacts, but to have the resources in our local area. And you've seen the spikes that we've had with 7 out of 10 of our Greater Manchester boroughs now in the red. We need those extra resources locally, because our local teams are much more successful.
Well, as I say, there is one system, and it's a system that works with both the national system, where very large resources can be brought to bear on one individual area, and then locally. And then, of course, there's the complex, there's the institutional settings where we need to do contact tracing as well. For instance, the care homes that might have a case where you need to go into the institution as opposed to the contact with the individual person. So that is, I think we're violently agreeing that the local element of that is incredibly important. But it's the combination of the two, where you can get both the scale and the local boots on the ground that is going to make this that is what makes this work effectively.
Thank you.
So will you transfer
last
resources?
Quick one, Barbara.
Just a final point. Will you transfer resources so that we can have more local boots on the ground? Because with the peaks we're seeing, that's what we need. We
have done that, and we absolutely have a policy to do that where we see the spikes.
Thank you. Just going to wrap up with two other areas not directly related to the pandemic. Dean Russell is going to ask on mental health.
Yep.
And then Laura Trott on maternity safety. So over to you, Dean.
Thank you, Chair, and thank you, Secretary of State. The 2 questions I've got are related to mental health, but also for one specific group, for the deaf community, who have been very anxious throughout the pandemic and moving forward. One of the biggest challenges, as you know, is there's 150,000 British Sign Language users across the UK, and the cost of the basic service, as I understand, to provide a BSL for those who are engaging by the telephone via an app is around £10. So it's cost about 1.5 million over the course of the year. As I understand it, I was reached out to by a charity called Sign Health, and they're saying that that service at the moment isn't being covered by the NHS. They're having to try and cover it as part of their charitable donations, and they're getting close to running out of money. So is it possible to confirm whether the ability to enable sign language to be available to all who need it is possible moving forward, and that the NHS could fund that, please?
Well, I'm very happy. I'm very happy to look at that. It seems very reasonable. Let me see what I can do.
Thank you. And the second questions really are around mental health, but in particular children's mental health. I'm conscious that for many years there's been a challenge around support and ability for children to get mental health support through the NHS and wider. I know there's been an awful lot of work done on that. Claire Murdoch has given excellent evidence to this committee. But looking forward, we're going to have mental health challenges for children who've been in lockdown and their families. What provisions are being put into place for the rise in mental health need, and also to ensure that that provision is as robust and as strong as possible in the coming months and years?
Absolutely. It's an incredibly important area where, within the increase in funding that the NHS is getting over the next 3 or 4 years, we are the fastest increase within the services in the NHS is in mental health. And within that, children's mental health is getting the fastest increase. So it's not just about the money, but the money, of course, is very important. And at the same time, we need to develop and improve access to services, including where appropriate and where it's best used using digital technology. But that isn't that will help, but it isn't the solution to all of these problems.
And may I also ask, just with regard to mental health provision, obviously at the moment people, if they need physical health support with medicines and so on, they would walk into their local pharmacist. I wondered if it's possible to look at whether pharmacists could also be a front line for mental health with regard to mental health first aid training, with regard to support, to be a sort of a signpost to additional services. Is that something that we could potentially look at, or has been looked at over recent months as times have changed?
Yeah, it's not something that I've looked at specifically. If we can make that work, I'd be open to it. We've put in the focus, especially for paediatric mental health, has been to put support into schools to make sure that they have firstly they have a mental health coordinator who can then make sure that the connections are made between the school and the local children and young persons mental health services. And so we've done it through schools, but I'm always open to ideas, and this ties together two things that are very important to me. One is the importance of having high quality mental health services that are easy to access. The second is the importance of putting more services through pharmacies who are there in the community, rooted in the community, and readily available. So I want to support pharmacies and I want to support mental health. You brought the two ideas together, but it's the first time anybody's put that idea forward, so I'd want to then go and reflect on it.
Thank you. And just very finally, to any parent who's out there, their children are just going back to school, anxiety may be high. If their child, they feel that their child needs some mental health support, what advice would you give them right now, please?
Well, in the first instance, they should contact their GP, or they should contact one of the widely available and excellent charities that provide mental health services, and in particular, for instance, Mind, the ability to get support. The single most important message from all of us is that there is help, and people should ask for it. And that often is the first and most important step in treatment for mental ill health.
Thank you very much indeed, Dean. And then finally, Laura Trott on maternity safety. Laura.
Thank you, Chair. Secretary of State, can you tell me, has there been a rise in either maternal mortality or infant mortality during the pandemic?
There has... the Office for National Statistics published the data on this, And in fact, they've published more data this morning. This is on mortality across the board. In the case of cases notified to the UK obstetric surveillance system, for those who have those women who've had coronavirus, there were 1,434 women who've been admitted to hospital with confirmed COVID-19 during pregnancy. 1,399 included additional case data, and the pregnancy outcomes for those were similar to, very slightly higher than, but similar to the outcomes for the rest of the population as a proportion. So this is something we monitor very closely, and I have a concern to ensure that we get the very best information out and published so that pregnant women and those who support them can take the very best possible decisions.
Thank you. You mentioned there about ongoing monitoring. What exactly is being done to monitor the effects of this disease? Because we obviously know it's very new, on pregnancy and on birth, and how is that being fed into clinical outcomes and commissioning? Yes,
well, the Dr. Jenny Harries, the Deputy Chief Medical Officer, is an expert in this area. The advice that she gives me is that in the first 2 trimesters there is no evidence of any particular impact of COVID that's different if you are pregnant. In the 3rd trimester, it is worth being cautious. There is not conclusive data, but there's a precautionary principle in order to, as there is with respect to many things in the 3rd trimester of pregnancy.
Thank you. In May this year, the committee took evidence from Jill Walton from the Royal College of Midwives, and at the time there were concerns about redeployment of key staff, including dual-skilled nurses, obstetricians and anaesthetists, and the effect that that's had on maternity safety. Have you taken action to address this, and are you satisfied that it's been dealt with?
Yes. One of the areas where if you call it the restart of the NHS has been essentially fully recovered is in maternity. It isn't a restart, of course, in maternity, because maternity services can't stop, whatever the depth of a pandemic, because there's a time limit, obviously. So this is an area where there's been an awful lot of work to make sure that the full quality of service is available and has been available as soon as possible. Clearly, there's the need for infection prevention and control and the precautionary principle that I mentioned, but it's an area that the NHS has been doing a huge amount of work on.
Thank you. Sarah, final question. So Sarah mentioned the very important issue about fathers being allowed to attend scans and early labour,
yes.
And I'm glad to hear that this is something that you're taking action on. You very kindly met the neonatal APPG to talk about the issue of parents being allowed access to neonatal care on an unfettered basis. Can you just confirm again that there will be action taken on this, so that we know that mothers and fathers, often in very desperate situations, will be able to access the neonatal unit without any obstructions?
Yes, I think you're right, and Sarah earlier was absolutely right to raise this issue. It's incredibly important. It really matters to me, and this is something I've taken up with the NHS, and I'm very happy to write to the committee within a fortnight with an update on progress, and to make sure that we take whatever action is needed to support, not only to support mothers and their chosen partner through this process, but also to support parents in neonatal intensive care, which is very important. And I heard loud and clear the message from the APPG, which is that parents aren't visitors, and throughout we've had a different policy for visitors as to for parents of children who are ill, and especially those who are seriously ill. But we need to make sure that we get that guidance and advice right.
Thank you.
Thank you. Just a couple of quick follow-ups on maternity safety. In the House last week, you talked to me about HSIB, which obviously has a very important role in terms of the independent investigations they do into maternity incidents. And obviously you couldn't say what was in the Queen's speech.
Yeah.
But do you think it's possible we could see that HSIB bill in the next year?
I very much hope so.
Okay, thank you.
I think that's as far as I can go without breaking some convention.
I will pine my hopes on your hope. And the second thing is, I wrote to you last month about the concerns of baby loss charities, SANS Baby Lifeline and the Lullaby Trust, about data protection law changes that could potentially mean that Embrace, who are, as you know, the people who collect the crucial data on maternity safety, might not find out about baby deaths if people have opted out. I just wondered if you've been able to look into that.
I am looking into it, and I'm very happy to write back again within a fortnight, if that's reasonable.
Thank you. And then last but not least, it wouldn't be a select committee if we didn't hear from Rosie, so I'm just going to hand over to Rosie, who's going to ask the last question this morning. Oh, Rosie, you need to unmute.
Oh, not again.
I want to hear the last question.
Thank you. Secretary of State, as COVID has encouraged rapid change in the way NHS services are provided, much of it good, but some of it with dreadful downsides. For example, face-to-face appointments with consultants are converted to telephone appointments. That works well quite often. But recently, a consultant from Clatterbridge NHS Trust told a patient that chemo wasn't working and that it was terminal, nothing could be done. Nothing was done to ensure that patient was not on his own. Do you think it's appropriate that we deliver that kind of news over the telephone without putting in or ensuring there's some support there?
Well, I think it's a really, really important question. And I think the natural instinct of everybody would be to say that should be given face-to-face. I'm also aware of some of the evidence that came up through the use of video conferencing, that there is some evidence that patients prefer to hear bad news when they can be with their family at home, when it is well prepared for and organised. So I'm certainly not endorsing the individual example that you gave. And Clatterbridge is a very, very good trust, and the staff there are excellent. But what I would say is that we shouldn't automatically reject the use of telemedicine even in this scenario, because actually some people find that receiving bad news at home is better rather than in the unfamiliar circumstance of being in a hospital. But of course it should be done in a sensitive way where people have the support around them. And I think we need to learn from how this has been done with an open mind as to what works well, what must return to being done face-to-face, and where we can use the advances in technology. Even as a huge enthusiast for technology, I wouldn't have expected, frankly, any evidence that people prefer to hear bad news over a video conference than face-to-face. And when I saw that, I was surprised. But once you think about it, you can understand it if it's done sensitively. I hope that's a reasonable and nuanced answer.
No, absolutely, Secretary of State. The objection is not to the telephone call. That's keep it safe as well.
Yeah.
I think the difficulty here is the consultant knows the message they're going to deliver.
Yeah.
The patient doesn't know what they're getting.
Yeah.
So if you don't check that they're with their family, then this actually caused grave mental health. A great drop in the person's ability to deal with their illness.
Yeah.
It was awful.
Yeah, I think we're on exactly the same page. I can absolutely empathise.
Secretary of State, you've been very generous with your time. Thank you
Pleasure.
very much indeed.
Thank you very much.
Session closed. Order.
Portcullis House.
The Wilson Room, 8th of September 2020. Health and Social Care, the Wilson Room, 8th of September 2020.